This study-specific video is being used to educate EEG reviewers on how to use the BASE score. The BASE score is an EEG grading scale for children with infantile spasms. The scale is founded on the idea that the burden of interictal epileptiform discharges and the background amplitudes are important features of hypsarrhythmia and are perhaps the most objective in that they can be measured. For example, spikes can be manually counted, and spectral analysis with digital EEG allows for the measurement of background slow wave amplitudes. BASE is an acronym that stands for Burden of Amplitudes and Epileptiform Discharges. Here on the left you see the BASE score in table format. A score of less than or equal to 2 is least severe and a score of 5 is most severe. We use a score of less than or equal to 2 because the current study utilizes 5-minute EEG epochs and not the entire EEG study. Thus, a BASE score of 1 for any definite non-epileptiform abnormality and 0 for normal cannot be used when assessing only 5-minute epochs. We will use EEG examples to illustrate how to use the BASE score. Before we begin, it's critical to understand several features of the BASE score. First of all, note the OR in the BASE scores 3 and 5, as well as the AND in the BASE score of 4. Later I will illustrate these details with EEG examples. Second, when determining the percentage of 1-second bins with an epileptiform discharge, we assess this within the most abnormal 5-minute epoch of the study. In other words, we use the epoch that gives the highest possible BASE score. Later I will show you how to assess the burden of epileptiform discharges when the percentage of 1-second bins with an epileptiform discharge appears to approach 50%. Third, when assessing background amplitude, there are several important considerations. The amplitude criteria are specific to the longitudinal bipolar montage. Other montages may be used if desired, such as to assess a specific finding, but when measuring the voltage of a background slow wave, this must be done on a longitudinal bipolar montage. In addition, amplitude is measured peak to peak, which is the same thing as saying peak to trough, and refers to background slow waves only. So for example, amplitudes of the following are excluded. 1. The slow wave associated with a preceding spike. 2. Hypnagogic patterns. And 3. Arousal rhythms. Furthermore, when measuring background amplitudes, slow waves of interest should be a common feature of the background, i.e. they should not be rare, although they need not be present on every page. Finally, regarding BASE scores of 4, 3, and less than or equal to 2, which utilize the greater than or equal to 200 microvolts criteria, it is only necessary for these high amplitude slow waves to be present in one head region. On the other hand, regarding a BASE score of 5, when using the greater than or equal to 300 microvolts criteria, these even higher amplitude slow waves must be present in 2 or more bilateral head regions. Everything we've reviewed so far can be found in the BASE score table or within the legend below it. On the right, you will see a scoring sheet. Please answer all questions on the scoring sheet unless the instructions ask you to skip a question. At the end of the scoring sheet, there are questions that require you to use your current method of EEG analysis to decide if the tracing suggests hypsarrhythmia or modified hypsarrhythmia. In addition, if it is one of the post-treatment epochs, which are marked by a patient number followed by a lowercase b, you are asked to use your current method of EEG analysis to interpret if the study suggests electrographic remission. For the purposes of this study, you will read the patient's pre-treatment EEG, mark with a lowercase a, followed by the patient's post-treatment EEG, mark with a lowercase b. This is being done to mimic clinical practice. For this study, all EEG epochs are taken from sleep. Now on to our EEG examples. You can see that I'm using a longitudinal bipolar montage with the left hemisphere on top, midline is central, and the right hemisphere is on the bottom. The current sensitivity is set at 7 microvolts per millimeter. This will need to be adjusted when measuring background slow wave voltages. I will use this montage for all EEG examples. In fact, in making this video, I use a 24-inch monitor with 15 seconds per page. This is optimal for 2 reasons. It provides a standard 3 centimeters per second page speed, and you can use the 15 second per page to your advantage, as I will explain in another EEG example when determining the percentage of 1-second bins with an epileptiform discharge. So let us review this first EEG example. This is a pre-treatment patient who is presenting with infantile spasms and very frequent multifocal spikes. Spikes are present in every 1-second bin during this 15-second page. This finding is consistent throughout the 5-minute epoch. If we return to our base score in table format, you can see that this patient has a base score of 5, given that greater than 50% of 1-second bins include an epileptiform discharge. Here is our next EEG example. This is another pre-treatment patient presenting with infantile spasms with a high burden of epileptiform discharges. There also happen to be common high-amplitude posterior slow waves. If I adjust the sensitivity, you can see that the spikes are predominantly in the right hemisphere, but are truly multifocal. I can also show you how to measure the amplitude of a slow wave. With this system, it's a right click and drag, and you can see here that the peak-to-peak frequency is 480 microvolts for this particular slow wave. So the findings we just reviewed were consistent throughout the 5-minute epoch. If we return to our base score in table format, you can see that this patient has a base score of 5, given that greater than 50% of 1-second bins include an epileptiform discharge. Of note, the regional high-amplitude posterior slow waves are not relevant to determining this patient's base score, given the high burden of epileptiform discharges. Here's our next EEG example, and it is an important one. This is another pre-treatment patient presenting with infantile spasms. For infantile spasms patients, it is very common, especially during sleep, for multifocal spikes to take on a grouping pattern. In fact, bursts of grouped spikes are often followed by sleep spindles. This phenomenon is particularly important to consider for this study, given that all epochs are taken from sleep. It is critical to the validity of our scale for this grouping pattern to be interpreted as grouped multifocal spikes as opposed to generalized epileptiform discharges. You can see from this study that the epileptiform discharges that are present for a majority of this 15-second page, a finding that is consistent throughout the 5-minute epoch. If we return to our base score in table format, you can see that this patient also has a base score of 5, given that greater than 50% of 1-second bins include an epileptiform discharge. Here's our next EEG example. This is another pre-treatment patient presenting with infantile spasms with a very high amplitude background. You can see that the background slow waves from at least 2 bilateral head regions exceed 300 microvolts. If we adjust the sensitivity, we can measure background slow wave voltage. So, for example, here in the left frontocentral region, there are slow waves that exceed 300 microvolts. And also in the right frontocentral region, again, there are slow waves that exceed 300 microvolts. In the left posterior head region, there are slow waves that exceed 300 microvolts. In the right posterior head region, there are also slow waves that exceed 300 microvolts. Of note, during this 5-minute epoch, there are no visible spikes. So if we return to our base score in table format, you can see that this patient has a base score of 5, given that 2 or more bilateral head regions have very high amplitude slow waves. As previously mentioned, the base score of 5 has an OR in the criteria. So even though this patient does not have multifocal spikes, this patient meets the amplitude criteria for a score of 5. I will mention here that the sentiment of two or more bilateral head regions is to capture the more widespread nature of the high amplitude slow waves. Here is our next EEG example. This is a pretreatment patient presenting with infantile spasms who has multifocal spikes, as well as common high amplitude posterior slow waves that exceed 200 microvolts. In this case, the burden of epileptiform discharges is less than prior examples and certainly less than 50% of 1 second bends for this 15-second page. These findings are consistent throughout the 5-minute epoch. I'll point out that we can adjust the sensitivity to measure these slow waves with voltages you can see that are easily exceeding 200 microvolts. But these slow waves are regional, in this case posterior. So returning to our base score in table format, you can see that the base score for this patient is 4, given that there are less than 50% of 1 second bends with multifocal spikes, but there are common posterior slow waves that exceed 200 microvolts. Here is our next EEG example. This is a pretreatment patient presenting with infantile spasms. Although the base score is often quickly applied, when the percentage of 1 second bends with an epileptiform discharge appears to approach 50%, it is necessary to use the scoring sheet as I will illustrate. Here's where the advantage of the 15-second per page becomes clear. A 5-minute epoch can be split into 20 separate 15-second pages. Each page should be assessed for the number of 1 second bends with an epileptiform discharge. 8 or more bends with an epileptiform discharge are a majority. 7 or less are a minority. So in this 15-second page, at least 8 of the 1 second bends include an epileptiform discharge. So if we return to our scoring sheet, an X should be placed in this box because, again, a majority of the 15-second page has 1 second bends that include an epileptiform discharge. So then we return to our EEG example, and if we scroll to the next 15-second page, you can see clearly here that there is a minority of 1 second bends with an epileptiform discharge. In this case, in returning to our scoring sheet, we have to place an X in this box because less than 50% of 1 second bends in this 15-second page include an epileptiform discharge. This process can be repeated until a decision is made on the burden of epileptiform discharges. In this example, there are 11 15-second pages with less than 50% of 1 second bends with an epileptiform discharge. So if we return to our base score in table format, you can see that the base score here is 4, given that there are less than 50% multifocal spikes. And although not illustrated, there are common background slow waves that exceed 200 microvolts in other portions of this 5-minute epoch. Here's our next EEG example. This is a post-treatment patient who continues to have multifocal spikes, though clearly less than 50% of 1 second bends on this 15-second page. In addition, the amplitudes of background slow waves are less than 200 microvolts. These findings are consistent throughout the 5-minute epoch. So if we return to our base score in table format, you can see that the base score for this patient is 3, given that there are less than 50% of 1 second bends with an epileptiform discharge, and the background slow waves are less than 200 microvolts. As a final note, a base score of 3 can also be found even in the absence of multifocal spikes if there are common background slow waves from at least one head region that are greater than or equal to 200 microvolts. In fact, we find this occurring commonly in post-treatment responders with high amplitude slow waves occurring in the unilateral or bilateral posterior head regions. This concludes this study-specific tutorial.